So it's a great question of which checkpoint inhibitor should be used in the second line. And the overarching answer is, we don't really know. The best data, the cleanest data, I should say, is for pembrolizumab from the KEYNOTE-045 study, because there was an overall survival benefit. It was clear. It was independent of PD-L1 expression. And so if you look at NCCN, that's essentially the category 1 recommendation. I think there's a lot of rationale still to give atezolizumab in this setting. I mean, if you look at the ITT population, the intent to treat population, it was a positive study. I think it's just a challenge. Whether to use the other agents, nivolumab, durvalumab, avelumab, they're options. And I think if a provider is very comfortable using those agents, it's not wrong to give it. It's very reasonable to do. So, I know there are community physicians out there who I've spoken with who are very comfortable using nivolumab. And so I think it's very reasonable from maybe their melanoma data or the kidney or the lung data. And so I think it's very reasonable to give it in bladder cancer. If you look at the efficacy rates of these agents, they're really very similar. They're all about 20% of patients, show that about 20% of patients respond, and the toxicity rates look similar. Obviously, they haven't been compared formally head-to-head. They probably never will. So I think in the absence of that, I think it's a reasonable thing to do. I don't proactively tell people to only give one drug, because I don't think that that's necessarily the right way to go about this.